Hello everyone and welcome to today's webinar, Autism, Nurturing Care Framework and Family-Centered Care, presented by Dr. Andy Shih. My name is Geronimus and I will be your moderator for today's event. Before we get started, I would like to go over a few housekeeping items so you know how to participate. You have entered this webinar into listen-only mode. That simply means that your microphone is muted so we don't pick up any noise from your end. We do welcome and encourage to submit your text questions at the questions panel in your webinar control panel. You can enter your questions at any time and we'll save them after the Q&A at the end of the presentation. Thank you for joining today. I would like to introduce our presenter, Dr. Andy Shih. Welcome, Doctor. You may now have the floor.
Thank you, thank you so much, Germinus. Good afternoon, everybody. It's really a pleasure and honor to be sharing some ideas with you this afternoon. I want to obviously thank the organizer for this opportunity to tell you a little bit about the work that we do at Autism Speaks around the world. So the title of today's conversation is Autism Nurturing Care Framework and Family-Centered Care. It is very much a focus on public health and policy making related to our community, autism, and related developmental disabilities. And the reason I'm sharing this this presentation with you today is actually very timely because, as you may know, today is the first day of the UN General Assembly in New York City, where the world leaders are gathering to talk about important priorities relevant to the global community, relative to development, and other issues. And one of the things that we'll be talking about in this coming week at the UNGA is our policies and context are important for the autism, individual affected by autism and their families in the world over. And so basically what I hope to do in the next 30 minutes or so is to answer the following questions. How global development priorities inform autism services development and implementation in low and middle-income countries. The reason this is an important question is because, as you know, when bodies such as the United Nations and other UN agencies establish these global development priority, it helps align policy and, more importantly, resources of the global actors that are engaged in development. And that includes stakeholders from health, education, social welfare, and other sectors. And as you know, these are all important sectors for our families. In the needs of our family are really best addressed through multiple sectors. It's not simply a health issue. It's certainly not simply an education or social welfare issue. And for us to really deliver the answers that are needed by our family, we need to look at the challenges in a holistic sense from a policy perspective. And that's why this awareness of the global context in which we're doing our work right now today is very important. In terms of not only in terms of the kind of policies and programs that we're able to develop, but how do we finance it? How do we sustain it in the context, a national context as well as a global context? So it's a little background for the Nurturing Care Framework. So it really started with some of the recent publication by Lancet. As you know, some of you may be familiar with the Lancet series. These are definitive synopsis, if you will, of, say, the science for key topic area. And in this case, as we talk about early child development, that came about a couple of years ago, and this slide really just stressed that if you're looking at it from a biological perspective, early childhood is actually a very critical period for human development, from preconception to birth to, of course, shortly after birth. There's really an explosion of development within the newborn child that really has that leads to the major functions such as high cognitive function and development language and other major sensory pathway are really happening in those early critical years. But of course, that doesn't operate in vacuum. We know that from neuroscience and other research that environment really is important in terms of influence outcome across the lifespan. Just as genetic blueprints are important for development, that will dictate, the risk factor that each of us may have, and also potential response and outcome in health and other aspects of life. The parents' health and well-being during pre-pregnancy, the pregnancy environment, and of course the environment, infancy, and childhood have also been found to really have tremendous impact on the eventual outcome of any individuals. So the quality and timing of early development really shape a child's future potential. And this recognition of the importance of early childhood and the environment and for successful development really coincided with a kind of a global success that we enjoyed in some of our really development target that we set for ourselves about a couple of decades ago. So the Millennium Development Goal, which is a set of global development priority established by the UN about 20 years ago, really focus on primarily reducing mortality. And one of the major objectives of that development package was really the reduction of child mortality before age 5. And this data from UNICEF really showed, as a global community, we've been extraordinarily successful. From 1990 to 2018, last year, if you look at the yellow lines, right, the one on the left tracks the mortality rate, or on the right track the actual number of deaths. What you see is really, globally speaking, we're seeing essentially a reduction of 50% or more of children dying before the age of 5 in all countries around the world. Now, some countries obviously do better. We know some countries have been able to reduce their child mortality to age 5 by 80-90%. But all countries have done well in terms of reducing child mortality. But I think it's important to remember that implication for the reduction in child mortality is that as more children survive into their 5th year of life, simple math just going to indicate that there'll be more children with developmental disability or disability like autism. And this is important to keep in mind. So it's not really two separate questions from public health, a challenge from public health perspective, the issue of child mortality and increase in children with developmental disability. It's just simply the flip side of the same issue. As you see more children survive, of course, you're going to see more children survive, but with some disabilities. So in response to these emerging challenges, the UN General Assembly actually several years ago issued another call to action in the form of what we call the Sustainable Development Goals. So these are a set of global development objectives that will, as mentioned earlier in the conversation, that will help activate resources, align priorities across public and private sectors, NGOs, donor countries, and so on and so forth. Even national policies and programs. And the idea is that by targeting priorities such as hunger and health and education, objectives are important for all of us. The idea is that we will be able to advance the global community collective interests in the coming 10 to 15 years. And the idea of nurturing care framework, which is first proposed by WHO, UNICEF, and World Bank several years ago, is really a global strategy that focused on 3 domains: not only the survival of children, the thriving, a productive life, a stimulating, enriching life for the children, for potential, that are part of the transformation of the environment that leads to a better outcome for our global community. So the idea of a global nurturing care framework is really a developmental strategy that's been mapped onto these global development priorities. To break it down a little bit more, to simplify a little bit more, the vision really is that we want to undertake global development, enhancement, well-being, and outcome of our global community with a vision that a world in which every child is able to develop to their full potential and no child is left behind. This is a critical issue, right? Because what we're really talking about now is that not only are child entitled to obviously to survive and to live, but also they're entitled to in the best possible circumstances that can promote a healthy development and a life lived to its full potential. The guiding principle for the nurturing care framework really is that the child's right to survive and thrive, right? As I mentioned earlier, and that we will leave no child behind. And this is obviously critically important for children with disabilities, such as children affected by autism and their families. And it's family-centered care. And I will go into a little bit more about this as I go on. But the idea is that it's not really, the focus is not really about just the child, what's happening to the child. But because the recognition of the importance of environment, right, the nurturing environment, it is for that, how important that is for healthy child development. The proposition is that by focusing on the family, will also lead to a better outcome for the child. It requires whole government interaction. There's a whole society approach. And implied within this framework means that there's going to be early identification. Early means early as possible to identify children with developmental concern. The support, the service we want to offer, it is a life course approach because it is a developmental disability condition. And as I mentioned earlier, it's because it's not just a health, education, or social protection issue. It's a challenge for the whole society where we need to take multi-sectorial action. So what does the framework really convey? So it is a roadmap for action supported by science of brain development, as I mentioned earlier, the impact on human potential, policy intervention, services that have an impact, test and improving implementation approaches. So, but what is it really nurturing care? What is it, how does it translate to action? What is it really about here? Well, if you look at the nurturing care package, there's really come in 5 major domains, right? Health, nutrition, security and safety, responsive caregiving, and early learning. For those of you who may be familiar with early child development, these should be familiar domains, right, for all children. I think the added emphasis is that this vision now is really inclusive, and a big part of it of this ability to be inclusive for children with different abilities, for example, it really resides on responsive caregiving. So more specifically, nurturing care is a set of conditions that provide for children health, nutrition, safety and security, responsive caregiving, and opportunity for early learning. Nurturing children means stimulating early brain development, keeping them safe, healthy, and well-nourished, pay attention to and respond to their needs and interests, and encouraging them to explore and providing them with opportunity to learn. And then finally, in order for caregiver to be providing nurture care, they must be secure, economically and socially, participate in social network, and most importantly, they need to be empowered to make decisions in the best interest of the child and inform in the important role that they play in the life of the children in their care. So the idea of caregiver and child is really at the core of nurturing care framework, that we can create an enabling environment. Of course, we'll want to have, for example, that we can create an enablement once we have things like policies and empower community and support services. But the core of things is really about the caregiver capability, right, to engage a child, to provide the child with the stimulation support that's needed that can promote a healthy development and good outcome. So this caregiver capability is where, at this point, our Autism Speaks really priority in terms of our global effort. And we do this through a collaboration with the World Health Organization. Some of you may be familiar with the MHGAP, or Mental Health Gap Action Plan. There was actually a meeting in Cairo last week where WHO brought together the ministries from around the world, including Oman, to talk about how do we enhance services for mental health. So the Gap Action Program is really a part of the solution or our tool that could enable and support the implementation of nurturing care framework / the Sustainable Development Goals. And you do so because it's an integrated package of key evidence-based intervention It's a collaborative network of community-based services, and it takes a life course approach, which we emphasize when we talk about urgent care framework in general. And most importantly, is empowers users and family. More specifically, if you look at this MHGAP intervention package produced by WHO, under the section of developmental delay in disorders, in the most current version, it says, offer parental training when available. About 4 years ago, when Autism Speaks first established collaboration with WHO, such a parent training package was not available. And so I'd like to take the rest of this presentation, really talk about how to develop this package as a family-centered care tool really support and speaks to the priority of the SDG and the nurturing care framework. So the caregiver skill training program planning process really started in 2013. There was a consultation at Geneva, Washington. I mean, in Switzerland, and experts from around the world, as well as internal experts at WHO, were brought together and explored this opportunity, development of a parent training package or a caregiver training package. Part of this effort resulted in a decision to conduct an extensive evidence review, systematic review of literature, and the information and the research that we drove from include studies such as this one that's really led by Atif Rahman. It was funded by Autism Speaks and was published in Lancet Psychiatry in 2015. And it's really it's a seminal study from our perspective because it really demonstrates for the first time that evidence-based behavioral intervention, right, from high-income countries such as the UK, in this case is the PAC parent intervention package from UK, can be systematically adapted and delivered by non-specialists in low-resource environment and achieve the same outcome as you would in high-income country. So I want to just emphasize that concept, right? Because what this piece of research and other research have shown, and that really stimulated the development of this particular package, is that behavioral intervention for autism, something that historically has been seen as to be in the domain of highly trained specialists, psychologists, psychiatrists, behavioral interventionists, and so on and so forth, can actually, like many other mental health interventions, can be systematically adapted and be delivered by non-specialists. The opportunity, the public health opportunity this represent, I think, is staggering from our perspective. As you know, one of the major issues for our community is really the issue of capacity. Having a number of experts who can provide evidence-based services, evidence-based support for children and family in need. Here is a path forward in which you can make available evidence-based intervention in a community setting without necessarily doing the same kind of training for specialists, right? The idea you can leverage community stakeholders to deliver evidence-based support here and now. So as part of this review, we're able to have an additional consultation and start the development of the program. And there was subsequent round, and as with most WHO project, there were subsequent rounds of reviews and both by internal experts as well as external expert. And the reason I want to show you this particular slide is because it was a deviation from the process, right? What WHO usually do. In April 2015, in collaboration with WHO, we brought together stakeholders. These are policymakers, therapists, parents, as well as individuals on the spectrum, all to Geneva. And we share with them the draft package that we developed to get that feedback. So we were interested in fully engaging the community to really understand, whether or not this package will be feasible and relevant and meaningful for them, given their reality. And their input was instrumental in helping us to further refine the package and to finally make it available at the end of an external review process 2, as a field trial package. So what is the caregiver skill training program? The aim of the program is really to make the CST that can be delivered by non-specialists, like I mentioned earlier. It can be adapted for use in low resource settings. So it doesn't matter if you don't have a ABA, a BCBA, or a psychologist, psychiatrist. This intervention can still be delivered by other stakeholders in the community. Of course, it's evidence-based. It's formed by research. We want it to be freely available to all the family who needs it, individual who needs it. The idea is that financial consideration should not be a barrier for access, and we want to make sure that this is makes sense from a system perspective. So we want to make sure that it can be integrated in existing services, whether that's in health, education, or social welfare. It doesn't matter, but it needs to be integrated into existing systems. The target population for the program is caregiver children, 2 to 9 years of age, with development delay or development disorders. Now, the next item is really important. A diagnosis is not required. Even though this intervention packet is strongly informed by autism research and autism and developmental disability, we decided in the end not to have that diagnosis as requirement for access of this package. And the reason we made the decision is practical ones. The first is that we recognize in many parts of the world, getting an accurate autism diagnosis as the way we understand it in high-income country like Western Europe and North America is basically not possible, right? Because we know that the expertise is not prevalent, and that and there's a cost associated with that kind of ascertainment. And we certainly don't want that to be a barrier for accessing what we think may be a helpful answer for many of these families. I think the other reason we decided not to require diagnosis is because this issue of stigma is much easier in our experience to be able to offer an intervention to a family that in general promotes better development outcome, which is absolutely true and which is the goal of this program, without necessarily having this label on the child, which in some community we've realized actually inhibits or limit access to the program by caregivers. The age range can be slightly adapted in different settings, and that we envision this as being referred primarily by referral by primary healthcare providers, community health worker, or specialists. The program content, we actually take a common elements approach. As many of you may wonder, children with autism are also different. Some are verbal, others are less so. Some have intellectual disabilities, and others do not. And some have severe, co-occurring medical condition, such as seizures, and others do not. So how do you really create a package that is meaningful for all of them? What we decided to do is take what we call common elements approach. That means the content of the program really focuses on strategy that can benefit a group of caregivers, right, with diverse needs. So the idea is that we try to target key issues that are important for children and families with autism. That is social communication and challenging behavior. So these two things are not diagnosis specific, right? They're functional, they're related to function and behavior. So the idea, it doesn't matter whether you have autism, pervasive developmental delay, Asperger's, cerebral palsy, Down syndrome. If you have challenges with behavior and social communication, this package can benefit your child. That's the basic idea. So program content is that it takes what we call the active ingredient from many of the behavioral packages that's out there. So through our systematic review, we identify what we think are the active ingredients that promote shared engagement and communication. For example, we took elements from Jasper, a package developed by Connie Kosry, who is another speaker at the conference. And we took elements from PRT, Pivotal Response Treatment, for behavioral intervention. And then, of course, we took some elements from the traditional discrete trial training that really facilitate behavior management. We take a positive parenting approach to promote positive child behavior and management challenging behavior. We encourage problem solving by the caregiver. And most importantly, and this goes back to the family-centered care concept, we are as interested in a good outcome for the child as it is for the caregiver, because we do believe that the better the caregiver do, the better they can do for their children. So the intervention will be delivered in the following format and setting. There's 9 group sessions, usually at some kind of community facility, health facility, schools, and so on and so forth. 2 to 3 hours each time they meet on a weekly by weekly basis. And then perhaps more importantly, there'll be 3 individual sessions in the caregiver's home with 90 minutes each. These home sessions are important because it allows the facilitator to help target intervention for the family's priority, the family's need. So this is really structure of the curriculum. What you see is that the houses are the home visit and the colored circles are group session, is that we start by getting the child and keeping the children engaged from the very beginning, right? So we go right after the social communication, and over time we layer on additional skills of play and routine, communication, behavior management, problem solving skills, and behavior well-being. And there's also phone check-ins by the trainers and parent caregiver to make sure that they're properly supported and that they are delivering the intervention in the home setting the way it's supposed to. And the expected outcome is that we'll see progress toward caregiver's goal for their child, whether it's, for example, being able to get dressed by themselves, or being able to tell the mother, what they want for dinner, things like that, to improve your child's joint engagement, communication behavior, improve caregiver's well-being, improve family functioning. And we expect the program to contribute to overall reducing stigma in community. And the reason we expect that is because the program leverages home routine and play, activities that occurs in every home. And the idea is by engaging the children in home routine and play, you're really including them into family life. So further enhancing the goal of family-centered care. So training structure briefly then is as follows. WHO Autism Speak trainer visits our collaborator in the country. We train the master trainers, and these master trainers are typically specialists, including psychologists, psychiatrists, pediatricians, neurologists, etc., etc. They're the one who then will lead the program in the country. They will be responsible for training facilitator, which are non-specialist service provider. They include nurses, teachers, social workers, peer community health workers, and peer caregivers. And then it's the facilitator then teach the CSC program to the caregiver and then deliver to the child. So what you can see is that the trainer model here allows us to make sure that the expertise remains within the country, and that there's a cascade training mechanism that allows you to quickly build capacity in a community setting without the expense of the time of having to train these specialists overall. So the program implementation toolkit has facilitator guides, comes with participant booklet, adaptation implementation guide, monitoring evaluation framework, and training and supervision material. Basically everything you need to be able to develop and adapt and launch a program in your community. So the current status of the program as of 2018 and the last year we have 20 countries. This year actually we're up to 23 countries that are actually implementing the program at various stages of development. Some are in the very early stages, getting started. Others are actually implementing RCTs. For example, we have RCT, randomized control trial sites in Canada, in Italy, in Ethiopia, in Kenya, Pakistan, as well as China. And we have also a new site that came on board this year in India, Iran, Nigeria, Serbia, South Africa. And I think the part that we're particularly proud of at this point is some of the work that we're doing in the Syrian refugee camp along the Jordanian borders. As you know, these families have been really uprooted and separated from everything they've known, including services for their children with special needs. And so in the camp environment, how do we continue to provide the support for the children? and family. And so fortunately, we're working with International Medical Corp at this point, and we have adapted the program, have started to offer to refugee family living in this camp. I think our understanding is that is bringing some relief to some family who are otherwise are really struggling with the situation. So that's basically it. And I hope that, for the past half an hour or so, I've been able to give you a sense that, the consideration that we take when we think about developing programs that could be inform policies and programs at a country level going forward, and how the conversation at the global level, how the recognition of the importance of not leaving any child behind, especially those who are vulnerable, those who has autism and developmental disability, that we need to have additional innovations that can allow us to better support their development and their well-being outcome in our community, so that indeed everybody, the global community, can benefit from better well-being and outcomes as part of the sustainable development context. With that, I want to thank you for your time and your attention, and turn things back over Jeronimus. Back to you.
Thank you very much, Doctor, for such a wonderful presentation. And I see that we already have questions from the audience. So the first and most common question is that a lot of attendees are requesting the copy of your slides. So will it be possible to share it?
Absolutely, yes, absolutely.
Okay, so after the presentation, we can send them by the email. Is that okay?
Yes, that's fine.
Okay, great. And we have a question from Mr. Ahmed Idris, which sounds, is there our online training for CST, or it is physical only?
Right. So that's a great question. So the status of the program right now is that we're collecting data from these pilot implementation in 33 countries at this point, and we will make a final version of this of the program available through WHO probably by the middle of next year. Currently, the training, because you really had to train non-specialists to deliver the intervention with fidelity, currently the training need to be done in person. But we are developing a e-learning version of this tool that is intended to go directly to families, and that will provide minimal additional support. Now, our expectation is that this e-learning version will be helpful for many caregivers, but it may not be as effective as a version that involves in-person training. I hope that answers your question.
Yes, thank you very much for the answer. And we have another question. Does WHO Autism Speaks have a practical intervention guide for countries for autism utilizing ecological public health model?
Thank you so much for that question. That's a terrific question. So the answer is not at the moment, but hopefully next year there will be one. I think, and I'll talk more about this at the conference early next year, where there will be more information. Currently, WHO, Autism Speaks, and UNICEF are collaborating to develop the first world report on developmental delay, developmental disorders, and developmental disabilities. And obviously, this report is meant to highlight neurodevelopmental disability like autism and intellectual disability that has historically been more neglected in the broader disability conversation. In this world report, we will have guidance and recommendations for best practices and policies that will enable, hopefully, the kind of program and infrastructure that could enhance well-being outcome for all families in the country.
Thank you very much. And another question is, why is there not an RCT in the United Kingdom?
So thank you for that question. So the RCT, the reason these RCT came about is really driven by the interests of the local stakeholders. So, for example, we have RCT in China because the Chinese government is interested in understanding, the impact of this program in various parts of the country. So they're funding that program. The UK has the services in the UK. Is very different than that in many low and middle income countries. It has a very sophisticated service system. It has both the private sector and the public sector provide services. And the issue of capacity is less pronounced, meaning that if you have a need, is not that difficult for you to access some kind of evidence-based support in the United Kingdom. And I think that applies in general to high-income countries. The reason we want to do the RCT is that we want to demonstrate to policymakers in some of these low-income countries that this is a cost-effective investment, that this will address one of the key challenges or priorities in their early child development portfolio, in their disability portfolio, in their mental health portfolio. And that's why having the evidence will be important for them. It will help them prioritize the adaptation of the program in these countries.
Yes, and I see that we have two more questions. I believe it's two last question is, so the first is, how long will take your training if we plan to attend at your university, please? Yes, hello, doctor.
Oh, sorry, I was on mute. Sorry about that. Thank you for that question. The training itself actually takes about a week on average, whether you're training the specialist or the facilitator. The time consuming part is actually the initial adaptation of the material, so it's culturally competent and is feasible for the local community. And then the other component that takes more time is actually that the trainee, they want to have to practice, right? To have to practice technique to reach fidelity for intervention, which can sometimes takes up to 3 to 4 months, depends on the trainee.
Okay, thank you very much. And we have one last question is, did speech and language therapists have any input on developing the CST? Perhaps ideas from Hanan.
So speech language research, like other evidence-based science, has been included in a systematic review. Systematic review, it typically is very comprehensive, and we set the evidence-based bar fairly high. Usually, we prefer a randomized controlled trial. So, as you know, in speech language intervention, even though we know that for many families it's very helpful, for many individuals very helpful, compared to other behavioral intervention, behavioral strategy, there's not as many as robust study using speech language intervention. However, there were a few, and they were incorporated and informing the development of this package.
Okay, thank you very much, doctor, for the answers. And thank you so much. And this concludes the presentation and the webinar. Thank you so much again for your wonderful presentation, doctor, and all attendees for being here today. Thank you, everyone, and have a great rest of the day. And for those who has requested the copy of the slides, we will send you by the email. So thank you very much and have a great rest of the day.
Thank you, everybody. Bye-bye.
Yeah.